everyone to we're just into August. We're about to start September. Yeah, the August meeting of the clinical network. And again, as I say, an official apology that we didn't meet last week, and it's very sorry about the last minute rescheduling because of illness. Kath, my colleague, is an apology tonight that she's just started her long service leave. And I will open the meeting before we proceed. So I would like to acknowledge the traditional custodians, the Wurundjeri and Burra people of the lands that I am speaking to you from today, and acknowledge the traditional custodians of the various lands on which you all live and work. I pay my respects to elders past, present, and emerging, as well as to the community members who may be participating in this webinar meeting tonight. Thank you. Tonight we're going to hear from Carolyn from 1-800-MY-OPTIONS, a bit of a snapshot about what's happening, and I always look forward to that. It's almost like a news rundown as to what's going on. I'm going to do a short presentation, which can be as short or it can lead to more discussion about a model that we have developed of providing IUD training in the community for GPs and nurse practitioners and nurses who want to learn to do IUD, and just some thoughts around that. And then we'll go around and see, as we always do, if anyone's got some news or updates or developments or anything that they want to talk about. And if there's any other agenda item, please feel free to mention it now. Maybe now is the time to share that link or tell people about the link. Kath has just sent through a live survey that we've developed about practitioners' experience with EMA, and we'll send the link through on the chat, but we'll also send it to our whole mailing list. I think that's what we decided, wasn't it, Sophie? So that will come through. And if you could, the more people who participate, the more, the better the validity of it. So, is anyone here for their first time who hasn't been before? No? Okay. Well, over to you, Carolyn, with the news roundup from the...
Thanks, Patty. We remain pretty busy. So all year, every month, we're ranging from anywhere from about 31 to 40 something calls a day. So we're pretty busy quite consistently. What we've been seeing, and as we were talking about as just before the meeting started, is we're seeing a lot of clinics needing to delay or pause things a little bit every now and again because people are getting sick. And so we're seeing how that impacts not just a service, because it might really impact the way that they can do intake or the way that they can answer calls, etc. But it also causes delays for them and sometimes confusion for people in the community that are looking for abortions. And I think, this is not something that we can prevent, but it's just something that we are observing a fair bit at the moment with clinicians going on leave because they're sick. So if anyone does have any of those kind of things happen, please reach out to us and let us know so that we can either put a pause on sending people to your clinics, or otherwise we can just let people know, leave a message and they might get back to you in 3 or 4 days instead of 1 or 2 days, for example. But it's something we've been seeing a fair bit. We're also, the number of callers that we have without Medicare is consistently significant. So just under about 10% of our callers. So we're getting maybe 750 or so a month, and about 10% of those have no Medicare card. And so obviously the access issues there are quite significant. We're also seeing more and more demand on the phone line. It's still not a huge number, but more demand for abortion without ultrasound. I think people are hearing about it a little bit more. People are curious. People are wondering how this might work. So I know that we are providing the details of the services that do have a protocol that they're happy to have referrals to. So we're providing that to a lot of our callers as well. I think part of that is also the fact that MSI started a no ultrasound service only, I don't know, was it about a month ago or so?
Yeah.
And so I think that because they're quite big on social media. They're doing a lot of work there. They're promoting their service a lot. It's front and center on their website as well. So people will be looking there and going, oh, I can't afford that. I'll see where else I might be able to get that kind of service. So that's just something we're seeing popping up a little bit more. The other thing we're seeing a little bit more of is a bit more demand for IUD insertion and more conversations around pain relief with that. A lot of people are asking about Penthrox with IUD insertion, or otherwise just talking about what are the pain relief options that I can be offered. What should I be asking my doctor about? Who can I talk to about this? Because I tried with one doctor and it really didn't work, kind of thing. That's quite a common conversation we're having. Those are the big trends that we're seeing on the phone line right now, or the notable things. In other news, we will have the 2024 medical abortion data up on the Victorian Women's Health Atlas in a few months' time. We're really keen to make this a little bit more timely. So we're setting up some,
What?
make it a bit more timely, because it's been a bit of time. We've had a bit of a delay getting it up. We're setting up some systems so that at the beginning of every calendar year, we can be ordering that data from Services Australia and get it up on online as soon as possible, so that we don't have that lag, so we can actually see the way that the work that we're doing is impacting access in the community. And it really helps services to understand what percentage of the local supply they're providing, or what is the supply that they're not able to provide, what's not being provided locally, for example. In addition to that, we're looking at a new version of the Realising Access report that we published last year. One of the things that was really missing from that was granularity at a regional level. I know that there was a lot of talk in the report about the difference between metro and rural, but that's not really enough. We want to see what the different regions are showing, particularly rurally. And so we're getting our data analyst on board again so that we can go through the data. That will also be able to include the 2024 medical abortion data from the Atlas, as well as 1-800's 2024 data. So it's going to be, the first report was the first 30,000 calls. This will be looking at the first 40,000 calls that we've received as a service. So much more data included in that, but having that regional breakdown is going to be incredibly useful when we're talking about access issues and planning issues and how we can manage the system to actually meet population needs. So stay tuned. We'll be working on that towards the end of this year and hoping to be able to publish that early next year or in the first quarter of next year. Fingers crossed.
Fantastic. Just to segue your comments about VMA, very early medical abortion, or medical abortion without ultrasound. And sometimes those two concepts are used interchangeably. They're actually a little bit different.
Yeah.
So VMA meaning, under 7 weeks with without ultrasound, usually without, but you can do without ultrasound up to 9 weeks, could. We've developed in conjunction with Ecta Neil, who's set up the service at Western, and that also involves the Bacchus Marsh crowd, like a skeleton, a structured skeleton about the things to consider, what you need, what you need to tell the patients, follow up, and what's different about it. So it's not just a repeat of an MTOP protocol, it's what's different about this. And we've been getting lots of requests for direction around this, and various institutions or hubs, their governance committee will have different attitudes, and we're certainly not in the business of saying you have to do it. There's been a bit of a push to do it from the Department of Health, but if groups are feeling confident, we've got something that is now in the pipeline. It's just with our comms team to be polished, and that will be on our website very soon. And
that's really good to hear.
Yeah, it was a very useful exercise to do, like what is really different about it, and not making it more scary, but making it less scary.
Yeah.
Part of the
and I know that that's one of the things when we speak to doctors that are registering with our service, there are often, we'll ask them about, what training have you done? Do you want connection with other training options? Do you have bedside ultrasound? Do you provide medical abortion without ultrasound? What's the lower gestational limit? And all of these questions then are often followed by questions from the doctors that we're
Yeah, it really gets them
registering.
thinking, probably.
Yeah, absolutely. And, we're the connector. So we'll be linking people through to the resources on the women's website or through to SHV or to SERSH or
Yeah,
whichever, or Sphere, whichever of those are going to be appropriate. But it does raise questions, and clinicians are really keen to have that kind of overarching guidance in addition to the RANZCOG guidelines, for example.
yeah. Paul's got his hand up with a question, probably, or a comment, maybe.
Yeah, thanks. It was more along the lines of when people are asking about the VMAs or abortion with an ultrasound, I'm just curious about the messaging, because I suppose there's always the caution, yes, you can refer to us, but they may still need an ultrasound, of course, depending on the clinical picture. So I guess you must, you presumably you throw that in as well.
We're really, really careful. So we'll let
Yeah.
people know that for some people, you can have an abortion without an ultrasound. It's relatively new in Australia, so not many clinics do it. But the clinics that do it will talk you through how we can make sure that it's safe, how we can make sure it's appropriate for you, and figure out whether it is the right option. Yeah, absolutely. Because that is one of the problems that they see that it's a potential thing and think it's a choice rather than a clinical decision.
Yeah.
And the statistics are pretty impressive that 40% will need investigation. Doing the screening test well, about 40% will be it'll be indicated to do a scan. So it's not just tie. It's
absolutely.
And that also can be the corollary of it being a misstep in patients' expectations also is that it can be reassuring, Paul, for the practitioners that if you follow the screening and you've screened them as low risk, their incidence of having an ectopic is even less than in the general community. So it can work both ways, can reassure practitioners and also help us manage expectations from the patients.
Yeah, well, expectation management is one of 1-800's big jobs around.
100?
Yeah, I'm sorry, but you probably won't get an abortion tomorrow at a public hospital. But it's all about those conversations, and it just goes to show that the health system's complicated and tricky and hard to understand for people when they're trying to access it. So we really appreciate these conversations as well that help us to consider ways to clarify the way that we're talking about it.
Any other comments or questions for Carolyn? We'll be really looking forward to the next publication of the data, because we quote the first 3,000 all the time, so that'll be really useful. So I'm going to share my screen now, I think. Oops, wrong one. That wasn't what I wanted. What have I shown you? That's not what I wanted. I want to, here we go. Yeah. Can people see that?
Yes.
Oh, goody. Yeah, so this was really just a wee bit of a romp through and to see what interest there might be out there, and to let people know that we're going to be increasing clinical site visits for IUD insertion in the next year. We've already done quite a number, but we're going to, we've now been able to ramp up the number of visits that we're going to be expecting to be able to do, which is really exciting. So training for IUD insertion, a local model. Why are we thinking about doing it? And really, what drove it was a response to demand. So you and your colleagues have been approaching us in large numbers saying, we'd really like to train in IUDs, but we can't get to the big city, or we can't give up a whole day, then come to the clinic, and then there may not be as many patients as you told us were booked. And we would really, really appreciate it if you came to us. And it made a lot of sense to us to give this a trial, in recognition of the barriers to training that so many of the practitioners are experiencing. You know, we're hearing about cost, distance, loss of work days, and it really seemed that the power of building on existing practitioner-patient relationships was such a beautiful thing to be philosophically pushing, rather than coming to a hospital where you haven't met the patients before, where you don't know the system, where the trolleys are all set up differently, where the protocol is slightly different than you might have been used to, and not developing your own local appropriate protocols, and not building on your own patient relationships. We also thought that it would be much more appropriate for patients because it's local and it's not something that needs to be done in a tertiary hospital. So from our point of view, you know, we're based at the Women's, and we have 5 clinics a week for insertion, and we have done a lot to cut down our waiting list, because we were discovering our failure to attend rate was just creeping up, and a lot of that was because people were waiting for so long they either ended up pregnant, had an abortion and got an IUD or an implant inserted, or they'd gone elsewhere, or they decided to continue with a pregnancy, etc. So by looking at that, we realized, you know, that most of our patients were coming from outside of the ring road, and or from suburbs where they were traveling over an hour. And the other thing that we thought of as a team is that it would be really destigmatizing for LARC insertion if it happens locally. It takes away that feeling that it's a hospital-based procedure and is by definition therefore dangerous. We've run some pilots and they have been very positive. And the things I wanted to share about the pilots was that we have had 100% insertion rate at every, we've done 10 pilots now, 10 insertion sessions, and we've had a DNA rate of less than 10%. Now, our DNA rate at the hospital runs at 25 to 30%, because people's lives are busy and they can't make it, you know? And so that was a very positive thing. The other thing was that we're hoping to, and we have already done this with the pilots, where that we were going to an area and we combined maybe a day or 2 days of IUD insertion with 1 or 2 GPs, with other things like running 2 to 3 implant insertion sessions. I'm thinking of when we went to Warrnambool, we did about 3 back-to-back, and the Grampians we did about 3 back-to-back, and then 1 IUD insertion session, and an options counselling session, and a session on how to deal with conscientious objection. And that was all developed because that's what the local people wanted. So wrapping it into like a traveling roadshow seems to work quite well. And the other thing that I just wanted to share was that the conversations, I was just thinking about Lou's description of being on the bus, you know, but that when you go out somewhere and you're in a tea room and you meet the practice manager who says, oh, what are you here for? And you talk about it. And then someone else comes into the room and they've said, oh, I thought Joan was starting to do this. I would be interested, but I didn't want to be the only one. And then you think, well, here's a chance to talk about it. Or they come and they say, I've just started doing MTOP and a lot of the patients want a Marina, and then I'm sending them somewhere else, and it's either costing them or they're not getting in time. And there was one GP approached us because she'd had 3 patients who'd all got pregnant waiting for her to do the training. And she said they shamed her into doing the training. So so we've started doing it, and we have developed a, I go to a new share, we've got a, I'll just share with you this other booklet. Can you see that? We've developed, and I thank my colleague Kath for this, we've developed an intrauterine device procedure training framework, okay? And we're not repeating documents that other people have done. This is about 10 pages, and it really just goes through what you need to think about, what equipment you might need to have, where the resources are, who you could talk to. And we found that quite a number of doctors who approached us hadn't actually, well, it had been a while since they'd seen an IUD inserted, and they'd forgotten maybe that you need a bed, you know, that that you need a bed and a light even, and what devices were needed and what you needed to do beforehand. But more so than that, it just revises the safe insertion techniques as well. So that's available and is on our website. I'll go back to the other presentation. So we are happy to open the eligibility up to people who are interested, but also who have shown that they have had some previous experience in sexual and reproductive health, and particularly in pelvic examination skills, so that there's a baseline for us to start with. And another thing that's really important when we're having a chat with potential interested parties is, have you had a discussion with your practice and your practice manager? Because, and we know that there's a bit of a synergy at the moment with some improvement in the Medicare rebates and increased funding for some of the hubs, and more hubs opening up, and also sexual and also women's health hubs in some of the hospitals opening up, that now's the time to kind of get the training out there. And we know that there are other national initiatives as well. So this is designed to be synergistic rather than competitive with anything anyone else is doing, because the demand is so great to train doctors. And as Carolyn said, a lot of patients are wanting these devices now and wanting to discuss pain relief and, you know, the best way to get an insertion done as an outpatient. So we've developed a bit of a protocol where anyone who was interested could talk to us, and we would talk through with them where they could get some resources for their professional development. RANSCOG offers a free online basic training, talk about OSCAPs. We've developed our own service. We'll let them know about Sexual Health Victoria, let them know about the various places where they could go and get even the theoretical training first. And we expect them to follow through the theoretical training before we would think about arranging the visits. And we would usually arrange 2 to 3 per clinic, and it really isn't a numbers game. You know, it's not necessarily that doing 20 would make you better. It's more about your previous experience and getting to a stage of feeling comfortable with both putting in IUDs, but also when not to put in an IUD. So usually about 3 sessions with 5 per session seems to have been so far where people get comfortable. Sarah's got her hand up.
Thanks so much, Patty. I'm really interested in the RN role in IUD insertions. Have you had many people doing that on the road?
Yeah, we've had nurse practitioners that we've had a training, but it doesn't have to be a nurse practitioner if a nurse was supported by her practice.
Yeah, okay, great. Because I know in Queensland, lots of registered nurses are doing IUD insertions, and it's not something that we see in Victoria. So and then you're right, there's nothing that says that they can't, but it just doesn't seem to be done. So yeah, interested to watch that space. Thank you.
Yeah. So the group that I went to just a week or so ago, the nurse who is the practice nurse there used to be an IVF nurse, and she did egg pickups. She did everything. She was doing pelvic scanning. So to my mind, she's extremely expert at pelvic exam. So she would be the next one to train. And so we thought that next time she might do some of them as well. Yeah. I always tell everybody that it was a nurse that taught me in Glasgow how to put IUDs in a clinic and in the Gorbals, actually. So it's certainly, there's no reason why not. And just to give you an idea about site visit, these are the Millies. This is the latest. They let me take a photo of them, so that's why they're here. The Millies are both called Millie. That's why I call them the Millies. On the right in the green is the GP, and sorry, on your right is the GP, and on the left is Millie, the nurse, who Millie, the doctor, says has done many more pelvic exams in her time than she has. So I think that answers the question. And they're at Jan Juck, and they're the group that were shamed into starting the service because of the return rate of pregnancies from some of their very well educated and very health literate patients. And so I'm showing that photo because it's got the bed in it. And so they actually bought the bed about 3 or 4 years ago, before they actually got round to training. And it's really is sort of an expensive but rate limiting step that the gynae beds need to be purchased. And it's one of the things that through the clinical champions, we're hoping to advocate with the Department of Health that there might be some funding for purchase of beds. They're also modeling the light. They had a really good light, a resus trolley off to the side, and pain relief strategies, and a bit more about the pain relief strategies to include the green whistle, but not to be solely dependent on the green whistle. And we also talk about how they're going to advertise their service and how far away, and are they going to accept patients from outside of their practice. And this is a list of the things that you need to have in your kit. And these are available as, I think Lou would say, could tell us the cost of them. But they're available in a pre-packaged kit, aren't they, Lou? And you can purchase them. She's going to talk.
Yes, you absolutely can. The thing that we don't like about these disposable sets is the tenaculum is really quite a sharp instrument.
Yeah,
so
yeah.
we actually use the other one. So because we do so many in Bendigo, and I'm sure, Paul, you probably do lots in your clinic too, we actually, it's actually cheaper for us to re-sterilize, which I know is not financially sustainable for GP practices, but certainly I've used those in the past. Yes, and certainly
So
when
have you got a sterilising unit at your practice?
No, we have a deal with the Bendigo Hospital, so we're
right,
very
I was going to say,
so we're very lucky. Yes, because
this group has got a deal as well. So
that's
the
right.
group that I've
Yes.
just been to are probably not going to use these throwaway
Yes.
ones.
Yeah.
Some of the throwaway ones are, you're actually throwing away metal as well as everything else, you know.
Yep.
It does bother us a little bit about how much plastic there is in there as well, versus having to get them cleaned. But that's something that we've learned that we really need to discuss before we go out, because and make it really plain as to what you need. What we developed was our own little box of tricks that we take with us, because a couple of times people didn't quite have the right equipment, and for the sake of just having one little dilator that might have made all the difference in an insertion in a nulliparous patient, you know, it might not have worked. But we would now go out with everything that's needed, but also really spend quite a bit of time on developing what's needed. And you probably have modified yours as the time's gone on, haven't you? Like what's your favorite sound and what's your favorite dilator and those sorts of things, because there are there's some variable quality plastic ones. Some are really good, others aren't quite so good. And as you say, some of the ones are.
Yes, we absolutely have. And I suppose the really big important thing about the bed is that when somebody's sitting in front of you and they want an IUD, just looking at their body habitus doesn't indicate whether or not it's going to be an easy procedure or not. So those beds are absolutely, you know, critical. I've actually, prior to having one of those beds, I just had a bed that just went up and down, and there was no space for even you know, kind of tilting in that, and it was really challenging. Yeah, so those beds are absolutely vital, and we've got them, and they're just brilliant. Yep.
Yeah, yours are like the chairs, aren't they? They tilt.
Yep.
Yeah, so there's different ones. Yours is probably more sophisticated than the one they've got at Jan Juck, but it worked really well. The other thing we talk about with people is selecting your client base. And so, you know, really starting with women who have recently given birth and are certainly in the fertile years of their life, it's not a contraindication that they're nulliparous by any means, and we have successfully inserted in lots of nullips with the GPs, but not doing it for initially anyway, not doing it for menopause management in someone with a higher BMI who's having her IUD exchanged after 7 years of amenorrhea. You know, that's going to be a tricky one. So pick your patients. And this group that we did just the other week, they were all patients who'd either just delivered or had MTOPs, and you know, MTOP 6 weeks ago or whatever. And that was the group that really was probably going to be the more steady client base. And then that's a photo of the resource of the bed they've got. It's called Comfy Care, actually. Cost them $2,500 to build, to get it and build it. This is a setup video, which is really easily available on Google, and we can give you the links to that. Just showing you how they set the trolley up. This can be quite useful. And of course, having demonstrable IUDs is really important, so that patients can see them and feel them beforehand. And we've got lists of lists of resources for the patients and takeaways and translated, and share that with the multicultural centres and all of the other people who've developed, like Better Health Channel, developed all those resources. So we're just sharing those. Just to go through that, you know, the expression of interest is to really contact us for a pre-contemplation chat. I think that's the way to describe it, so that we can talk about, well, what's your situation? Are you likely to be able to do some training and then convert to being someone who's going to be an inserter? Have you done any training before? As you know, the drug company has got a pelvic trainer, which is doesn't feel like a pelvis, and has got a metal cervix, and you look on a screen to insert it. So that doesn't necessarily translate to a live patient insertion. So we go through what the training is and what the support is and who else is there, and try and think about training 2 or 3 people in the area at the same time, and clump them together and talk about the practice support and their likely consistent client base. And our aim is to develop more opportunities in 2026, and we have the ability to do that. So we're really interested in hearing from people now, and ongoing for the rest of the year. We've got enough bookings for the rest of the year, so it's likely that, you know, if you want to do this and we haven't already had contact with you, it'll be in 2026. These are just some other considerations. When I took down my box of tricks a couple of weeks ago, I took the Chubba Chops, and I cannot emphasize enough that they are the best distractor in the world. A fun fact about Chubba Chops is that the design was by Salvador Dali, which I think makes them even more cool. And that was in the 60s. He designed the Chubba Chop emblem, and it's still going. Anyway, that we've decided there are 2 sorts of women. There's the woman who can undo a Chubba Chop single-handed, because she's had 3 or 4 kids and she knows how to do it quickly. And then there's the idiots like me that need help or a pair of scissors. So either way, it's a very distracting thing. And I think the sugar really helps with pain relief. Certainly the patients like it. The other distractors we use are, you know, things like glitter sticks where people can watch them, or this is Panic Pete, and he gives a really, really satisfying pop when you squeeze him. We have some other fun novelty ones, chilies and bulls and things like that that you can squeeze, but Panic Pete's quite a favorite. And to have something that they can pre-hold so that they can see that the Marina or the Kylina or even the small copper IUD is not as big as they thought it was when they bought the packet. I've put a photo there of xylocaine spray. I'm quite a fan of the xylocaine spray to take away that pain with the tenaculum, the randomized controlled trials have never been performed. They've never been randomized. They've always been based on the provider's opinion. And so we really don't know if they really make a difference. But I make quite a show of putting quite a lot of xylocaine there, and it does seem to make a difference. I don't know if you would agree or disagree. Others, happy to talk about it. And the Penthrox, of course, we're very aware of the push for Penthrox. We're also very aware that hospitals on the whole don't fund them. So if they're coming to a hospital-based service, the patients actually have to bring it with them. What we have done is we've got 2 or 3 in each of our clinics that we have done, prescribed through doctors' bags. And so we have them there, and we hardly ever use them, is what we're finding. If they're there on the bench and we talk about needing, having it there and available, we would probably use it less than 10% of the time. And we did run a pilot study on its feasibility and find it really quite feasible. But we also found that we were throwing away, 3/4 of the medication. Patients were only requiring 2 or 3 puffs, and so it's really a very wasteful thing if patients were having to buy it. So in general practices, and I'm sure with you, Louise, and maybe at SHV, you can do it through the doctor's bag or whatever, and you can have it on the bench. But I'd be interested in what your experience is. But patients seem to quite like that we've got it, and everybody knows about them, because everybody's got it, knows about them on the footy field or wherever else they've been used. And I think just even opening up the conversation that we've got a variety of pain relief. And we also recommend pre-dosing with analgesia, a good dose of a non-steroidal before they come, and that they've come not fasted, because the number of women that turn up who haven't eaten and are feeling a bit faint anyway. So those were just my thoughts about it. And as I say, it has been one of the most enjoyable parts of what I've done this last year, and I'm really keen to expand it, because it's community-based, and then other things happen, and the incidental conversations and the incidental education sessions that happen, and the feedback that we get has been really great. And we are setting up an audit of it, and the outcomes are our insertion rate, number of patients managed, and then the number of practices that after the intervention being we go and teach, have they continued to insert, with the idea that, then some of the hubs, Lou, will become the super trainers, and then they'll train others, so some hub like yours that have done so many can then train locally. So that was really just what I wanted to put out there, and to ask you to contact us through the Clinical Champions Network, myself or Kath, and happy to have a chat with you about it and get things started. And I'll open it to any comments or how others have found their services. Lou, you started small and then you've just sort of got enormous, haven't you?
Yeah, thanks, Patty. I mean, everything that you've kind of outlaid here is really kind of how we started with yourself way back then. And speaking for myself, it was one of the big key things for me to do and become competent at, once becoming a nurse practitioner. And we're very delighted. And I suppose I was just reflecting when you talked about picking your picking the people that you start with. We've just finished training one of our GP registrars, so one of our senior GPs, Dr. Louise Manning, has just so our GP registrar who's here for doing our extended skills and sexual and reproductive health, which is just brilliant. So one doctor's going on maternity leave, the other doctor will be experienced to do that, and it has taken quite a longer period of time. I'm interested when you said 3 times 5, 15. I think just because we get so many varieties, so we do a lot of trans people, we do a lot of nullips, I probably do significant proportion of people under the age of 21 than over. And interesting about the Penthrox, just yesterday I had 2 young people coming in, one's 21, one's 17, and both of them had heard that you could have Penthrox. And we're very, very keen to explore a Mirena just because of that. So prior to that, that would not have been an option, you know,
Yeah.
in terms of that, because of, you know, their knowledge around an examination. Certainly we have
So
it
it
on.
opened a door for them.
It really did.
Yeah.
And the whole thing that you can actually have this procedure now, you know, at 16 or 17, and it to be so effective, you know, for your not only your wishes, but all your symptoms. In terms of, you know, people post MTOP and people post birth and the reproductive age, certainly we don't use much Penthrox at all. And even we don't use a lot of Xylocan spray. Generally we can, you know, pop it in. Yeah, so we're very, you know, we're very fortunate. We're very fortunate, and I don't know, and I think that would be very useful for the services to have a backup. So we always have at least 2 inserters on at the day, which means that if you're struggling a little bit, you've actually got another pair of hands. So we don't have very many, you know, kind of failures, I suppose. We've had a funny run with Mirenas that have kind of deployed incorrectly. So that's an interesting thing for us. And because we do quite a few coppers as well, you know, there's always that, you know, conversation around, you know, copper IUDs, and the Mona Lisa ones, which we purchase, are very, very tricky, you know, in terms of handling as an inserter. So you need a bit of practice with that. Yeah. So, you know, I think we have a very interesting program, you know, and we have a, you know, the thing I suppose that I wanted to talk about was around the fee structure, you know, and the nurse's role in a GP clinic, and the how that the discussion around how that GP clinic and the practice manager can optimize, you know, the nurse's time, as well as, you know, being able to provide this service. And that's always a challenge. Yeah.
Before we move on to Paul's question, can I just ask you a question, Lou? Do you do them as like a clinic, you know, so there would be an afternoon where it's insertion, or do they just build it in? Because
Yeah,
there
yeah.
seems to be an economy of scale involving the nurses if you were doing several in a row.
Yeah, yeah. So we definitely do a clinic. So Thursday is our clinic, and so we have 3 inserters, and so we have kind of, you know, morning, over lunchtime, and in the afternoon, and one of our nurses is blocked out for the whole time. We actually have the luxury of having a room kind of set up. It is actually where our nurse does all her other work every other day of the week. So we actually would have someone come into my room, do all the preparation, sign the consent, and then move down into this other room. So it kind of is a very kind of structured way.
A good workflow.
Yeah, but we do actually have random ones in terms of people, because the hardest thing about being in regional town is someone saying, well, I can't come in on a Thursday. You're only doing them on a Thursday. It's like surgical abortions are only every second Friday, you know, like access is really, really important. Yeah. So we have to be mindful of that. Yeah.
Paul, you had your hand up.
Oh yeah, it's just a follow on from the Penthrox. We have it there and available, and we tell patients it's there, and sometimes that's enough to kind of reassure them. And we have used it, and it's certainly, when we do it, it's made a difference between fitting one and not fitting one. So I think and we use it, get it under the doctor's bag, of course, rightly or wrongly, but we do. And like Louise, I tend to do them on an ad hoc arrangement. But I think if we're beginning to do more, it would be good to have a set day, but acknowledge Louise's comment. Well, not everyone can come on a Thursday or a Tuesday or whatever it is. So we tend to fit them in at the moment where we can, and to suit the patient. Yeah.
Any other comments? Or
I'm just going to add in that, again, when we're talking to people about IUDs, having that conversation about, you can have a chat. You will have a chat to the clinician about pain relief. Talk to them about what you're worried about. Makes a big difference, and people feel really reassured when they know that there are options available. And also, I think talking to the providers that we know are do Penthrox with IUDs, they say exactly what's been said by everyone else in this meeting today, that they've got it available. Don't use it an awful lot, but it's there, and it's just that reassurance that it's sitting there and it's ready if somebody actually needs it. This is a really consistent thing that we're hearing across all of the clinicians that do it, whether they're in private practice or in community health or elsewhere. I think in private practice, it is a little bit different. Most are charging about $70 or so extra for Penthrox use, which I think is pretty close to the PBS price. So it's a cost that it's in that private practice model. But yeah, it's just what we are seeing as well. It's very reflective.
But if they didn't have to pre-buy it, you know, and then not need it or waste most of it. Sarah.
So SHV, we've just had some ventilation put in one of our IUD rooms. So we are going to be able to offer Penthrox as part of an option for people. We will be supplying it from the clinic. So if you don't need it, you don't need to pay for it. But we do need to, it will reduce how many IUDs we do on that day, because the amount of monitoring that we're going to be doing post Penthrox use elongates how long someone's actually in the clinic room. So there's some challenges around the bookings around that, but it's great to have an option. And we same thing, people are really, really wanting it in the community as an option for them. So having some special ventilation with engineers put in to make everyone safe while they're using it has been really exciting. So we'll let you know as soon as we've got that rolled out and the new bed actually arrives for the space.
I'm very interested.
It always makes me laugh, Sarah, because when the ambulance doors open at our hospital, and the woman who's been in labour and been on Penthrox for an hour in the ambulance, when they open the door, the stench is incredible, and there's no ventilation. And then the first thing that happens at the obstetric hospital is they snatch the green whistle from her, and then she's got no pain relief till she gets to birth suite. And then they fire up the Entonox. It's insane.
But even we've had to order, and I'm sure for those of you in tertiary centres, it's not you would just have these around, but like pharmaceutical bins to dispose of the used Penthrox in. Like there's a few layers of things to work through logistically. So it's been an interesting process to be part of.
And I think it's all part of being responsive to patients and acknowledging the patients have done research and they've got concerns, and it really goes back to having a great, I just keep on being taught this every time I go out. It's all about the great teamwork, you know, and when they know that doctor, they've known her for some time or him for some time, they know that nurse, they play basketball with them, whatever, and they feel really comfortable in that room to begin with, and then they see a good relationship. I think that makes a difference to anxiety and therefore pain experience. So all of these things work together.
We also got some new posters for the ceiling, and there's hidden objects in them. So if people like the visual distraction looking at the ceiling.
Nice. You try and find this or that.
Yeah.
That's a good idea. Okay, well, I've talked long enough, but we'd love to hear from you, and please put it out there. And I guess, Carolyn, you can say to people, have you approached the Women's for Training yourself when you're talking to people? Let's hear from people around Victoria. What's happening in your area? Paul, what's happening down in far Gippsland?
It's been a little bit of progress. We had a visit from LRH. They've got some funding now, I think, to run the women's clinic or whatever the funding is. There was certainly some movement to expedite the surgical terminations, which we've had real difficulties with. One of them being that they are in the throes of potentially allowing us to do all the workup for them, consent, etc., and then basically refer them in with all the bloods and so on and so forth. They would simply stick them on a list and avoid that double handling of then
and you do the consent and everything.
It's a real change. So it's kind of in its infancy. There's a bit of discussion, but it looks like we've had a bit of a win there. Interesting about the IUD discussion, we have suggested that they send their straightforward ones to us as well, but we're still working on that one. But there's certainly been a little bit of movement in a positive way, which is good in terms of the surgical terminations, which, as you're aware of, we had real problems with and were referring
Yeah.
elsewhere. So
Is it a regular list, or is it still a fit around what?
it looks like they're going to have a regular list.
Right.
The numbers, of course, are small, so I guess if it's not used, then they'll give it to something else. But it does appear that there's been some movement there to facilitate the surgical terminations, which is great. Yeah.
And is it 12 weeks? Is that their cutoff?
They still are, yeah. It's yes, basically. We're pushing, but I guess it's little steps and baby steps. But it's certainly been a significant movement compared to previously. We did, touching on early medical abortion with that ultrasound, we did one, and of course we finally had our first ectopic. What was a little disappointing, it was actually remote support for sent elsewhere, and the nurse involved got bawled out by the O&G registrar, which I thought was inappropriate. So I did suggest that she should ring me, as I was the prescriber, but of course heard nothing. So anyway, the nurse involved is fine, took very good notes and good documentation, so there really wasn't any issue. It was just I think the response from the O&G registrar was a little disappointing. But
undereducated.
So otherwise, and that was a lesson as well. She was a lady who, talking about on Karen's comments of increasing numbers of people without Medicare, she was an overseas visitor or worker, and so did have follow-up arranged, but failed to respond on 3 occasions. That inevitably, with hindsight, we're just thinking a little bit about this as to whether people with in that situation where maybe English is a second language as well are the right people for this sort of procedure. It just made me think a little bit that maybe it isn't, and we should be eyeballing them to ensure follow-up and so on and so forth. But there's learning curves obviously all the way around.
Well, that's great, and really good to hear about the surgical service, and maybe that's something we can support them with in expanding up to 14 weeks.
That would be good. That would be good.
Yeah, so that's great. Sarah, do you have anything you wanted to add? That's great news about your ventilated room and being able to get that Penthrox going. Lou, apart from your upcoming long service leave?
Oh yes. So we've had I think our biggest month in MTOPS at 35 MTOPS last month.
Wow.
Which was pretty full on. So it's very interesting what Caroline was saying. We've got an increase in people without Medicare, and so and this is really interesting in terms of service and the cost of a service. So we do so much conversations about options, about cost. Do I have this? Do I have a surgical one? How much is it going to cost to go to the hospital? Do I do a medical one? How much is it going to cost? What do I need to do? And often English is a second language. Do you know what I mean? So then you're having, kind of not necessarily having to have interpreters all the time, but sometimes having to interpret it. So we're really finding that that extra timing is really quite significant, and we're going to have a little bit of a conversation about that in our clinic, because a lot of that is the nurse's role. And I can imagine if that was in a GP practice role, the GP would say, there's no way I'm doing this, sometimes we might spend 45 minutes an hour trying to sort things out, and so it's just it's doable in a hub but not doable in private practice. So that's really interesting, particularly because we do quite a few VMAs and do quite a few 1 and 2s on the same day, particularly because people do travel, or they're quite insistent. There's actually quite an assertiveness now in our community, which is great, but you also have to have that kind of professional conversation about what you need to do. The other really interesting, so we're very busy with MTOPS, quite busy with our IUDs, and I really just wanted to talk, concur with what Sarah said about with Penthrox and then the observation time. We've had quite a few people that have become, quite nauseated and needed, some tender loving care. And we're very lucky we have like a couch on the outside of the room, or sometimes even a spare clinic room. And the other day I had a woman, with a significant neurodiversity, and she just had to kind of wait, you know, for 45 minutes until kind of the Penthrox was, you know, kind of out of her system. And so, you know, that does kind of impact. And so sometimes we have to be able to, you know, say to the next person, you know, we're going to be a bit later. So backing them up one by one can actually be really challenging too. So that's the other thing in terms of, you know, we never get it right, you know, all the time, but it's very interesting. Yeah, so we're doing very well. I think we've got the commissioner of the LGBTIQ commissioner coming to Bendigo tomorrow, the diversity commissioner, looking at Thorn Harbour Health Country and our diversity and our transgender clinic that's been opened for a few weeks now. So so that's really good.
Is that at your
Yes,
wow.
yes. So we've got a transgender clinic run by 2 GPs for adults predominantly. Yeah, so that's been a fantastic initiative. Yes, great. Yes.
You're always innovating there. And
yes.
I really take that point about, you know, getting to a critical number of MTOPs, you know, because you see the patterns. It's much harder if you're a GP, you're doing one every maybe 2 or 3 weeks, you know.
That's right. Yeah.
That mass of, that doesn't sound right or not. Yeah.
And as a hub, it's an expectation that all our GPs do them. Do you know what I mean?
It makes more economic sense if you're doing a large number.
Yeah,
you know?
That's correct. Yeah, that's correct. Yeah, so all good.
Anyone else have anything they wanted to share? No? Well, that was a great meeting. When is our next one due? We would have one more, wouldn't we, Soph?
So we do first week of December, 2nd of December.
First week of December, okay, before everybody has their Christmas dues, we'll fit one. If there's anything you want us to talk about, or an interesting case, or something you've read, please let me know, because I'm always looking for ideas for the presentation. So it's lovely to see you all, and have a good evening.